Did you know that taking more medicines can sometimes mean more problems? Welcome back to our medical knowledge series. Today, we are discussing a critical challenge in geriatric care, polypharmacy in the elderly. Polypharmacy is generally defined as the concurrent use of 5 or more medications by a single patient. While it is incredibly common among older adults due to multiple chronic conditions, it isn't always appropriate and significantly escalates the risk of adverse outcomes. Our ultimate goal must always be the right medication, at the right dose, for the right patient, and for the right duration. But why does this matter so much? When an elderly patient is on a long list of medications, the risk of adverse drug reactions and dangerous drug-to-drug interactions skyrockets. This often leads to poor adherence, cognitive impairment, a higher risk of falls and fractures, frequent hospitalizations, and ultimately, a much lower quality of life. The risk is especially critical for individuals aged 65 and older, those with multiple comorbidities, cognitive decline, or renal and liver impairment. To protect our patients, we must actively screen for potentially inappropriate medications, often guided by the Beers criteria. Common culprits include benzodiazepines like diazepam, which increase the risk of falls and cognitive impairment. Anticholinergics can cause severe confusion, dry mouth, and urinary retention. Long-term use of NSAIDs poses serious threats like GI bleeding and acute kidney injury, while long-term PPI use without a clear indication increases fracture risks. So, how do we approach this systematically? We use the 5M model. First, medication list. Maintain a complete and accurate list of all prescriptions and over-the-counter supplements. Second, mentation. Review how these drugs affect their cognition and mood. Third, mobility. Assess fall risks and look out for drugs causing dizziness. Fourth, multimorbidity. Understand how all chronic conditions interact. And fifth, what matters most, align treatment with the patient's personal goals and life expectancy. This brings us to the art of deprescribing. Remember, less is often more. Deprescribing is not just stopping medications, it is an active therapeutic plan. We must assess if each drug is still indicated, safe, and effective. When appropriate, taper drugs gradually, especially benzodiazepines, PPIs, steroids, and beta blockers, and monitor closely for any withdrawal or recurrence of symptoms. Be highly vigilant about dangerous drug combinations. For instance, combining warfarin with NSAIDs severely increases bleeding risks. Mixing ACE inhibitors with potassium-sparing diuretics can trigger hyperkalemia, and pairing benzodiazepines with opioids can cause fatal respiratory depression. Always use interaction checkers to stay safe. To wrap it up, make medication reviews a routine part of every single elderly patient visit. Monitor their renal function, LFTs, and electrolytes regularly. Polypharmacy is common, but it is not always necessary. Review medicines regularly, deprescribe when risks outweigh the benefits, and always individualize treatment based on patient goals. Right medicine, right patient, better outcomes.